Welcome to the shoulder complex, part 2 lecture. Today we'll be looking at shoulder mobility muscles, muscles that move the shoulder joint around versus more of our stabilizing muscles we looked at prior, those rotator cuff muscles. Here again, we have the bones of the shoulder, starting with the scapula. We have these various aspects of the scapula, just to review: the superior border, the superior angle, the inferior angle down below, which we can't see so much in this shot, but we can see it over in this drawing on the right. And then we have the medial border of the scapula, the spine of the scapula, the supraspinatus fossa. Remember, that's where our supraspinatus muscle lives. And then this infraspinatus fossa, where the infraspinatus muscle attaches. And we have this lateral border where we looked at that teres minor. And then we have the glenoid fossa, where the head of the humerus, one of our other shoulder bones, sits. Then we have this lateral view of the scapula, where we can see this acromion process, which you can see the acromion also over on the other side here, butting up against the scapula bone. So here it is without that scapula, without the clavicle bone articulating with it. And then we have that coracoid process, which sticks out anteriorly. And then we have the spine. We can just see a little bit of it from this angle, that glenoid fossa, that shallow socket. And then this lateral border, which is where the armpit is, right? And sometimes we call that the axilla, the axillary border here. All right, moving on. Here are a couple more bony landmarks for you in this picture. The supraglenoid tubercle, this is where the long head of the biceps attaches. And the infraglenoid tubercle, this is where one of the tricep heads attaches. And then we have the bone of the humerus. So here we have the head of the humerus, just again, a review here, that greater tubercle, lesser tubercle, the intertubercular groove. And then we also have the anatomical neck here, just situated between the greater tubercle and the head. And then we have the surgical neck down below. You don't need to know those too much for this class, but just throwing those out there. And then we have the deltoid tuberosity, and we will be looking at the deltoids today. So they attach there. Now we could also say the deltoid, but there are 3 pieces to it, which we also can break down into the anterior, middle, and posterior deltoid muscles. On this next slide, we are taking a look at the ligaments of the shoulder. I am not requiring you to memorize any of these ligaments, but just again review that the ligaments of the shoulder are quite lax until the shoulder is in extreme ranges of motion. And so it is very important for the muscles of the shoulder to be nice and strong to assist with the stability of the shoulder joint. Here again, we see the ball and socket joint of the shoulder. And the anatomical name of the shoulder, let's remember, is the glenohumeral joint. So it's made up of that glenoid fossa and the head of the humerus. And there are very much common injuries to the shoulder joint, and we reviewed them more deeply in the last slideshow, but we will just briefly look at them here again and review that rotator cuff tears are common. That was from, again, our last lecture. Ligament tears, as we were just looking at in the last slide. There are many ligaments and they're quite lax until those full ranges of motion, and they can get torn, especially in those overhead throwing sports with high velocity. Impingement syndromes, because there's not much space there. Subluxations and dislocations, the head of the humerus not sitting quite correctly in the socket or dislocating completely. Bursitis, the inflammation of the bursa in there. Frozen shoulder, also known as adhesive capsulitis. And labrum tears, remember that lip that sticks out around the edge of the glenoid fossa to create a little bit of a deeper socket. So here's a picture of some of those structures. And we have the labrum over here, which again can get torn. We have the bursa, which can get inflamed. Just a couple ligaments there. And then down below, we can see that bursa, how it's just not very much room in there. Everything's just buttoned up against each other once we lift that arm out into abduction. And then when we come up overhead, if we continue to lift that arm up overhead, it's very easy to get into a pinch. So let's review the shoulder movements, remembering that these are different than the shoulder girdle. So the shoulder movements we can think of again as the scapula bone staying still and the head of the humerus moving in that articulation against the scapula. I'm going to go ahead and pull out of the slideshow and we will look at scapula and a humerus. All right. So you're looking at the posterior view. So I'm just going to now turn it to the lateral view for you. All right, here you can see that coracoid process and the acromion process. And here's the head of the humerus. And so we have flexion of the shoulder joint and extension of the shoulder joint. And from the side, now you're looking at it from an anterior view. This is abduction and adduction. Then we also have external rotation, try not to subluxate, and internal rotation, external and internal. All right, and we have circumduction, which is a combination of all of those movements. And one I almost forgot, but I'm not going to, is horizontal adduction and horizontal abduction. All right, now here again, remember it's the greater tubercle. And here is that neck of the humerus. And notice how there's this little dip in the neck here. And then there's this bulbous, almost said trochanter, tubercle. All right. So when we go into abduction from an anatomical position, here's the anterior elbow joint, right? Imagining the bones below. Right, if we just keep going out, notice how that tubercle gets so close up there, and then it's going to butt into the AC joint, the acromioclavicular joint. And so it can only go so far, and then the scapula is going to have to angle to lift the arm up higher. Okay, so when someone gets into a pinch there, and even if not, a nice way to be able to get more range of motion with allowing more space in here, and then also allowing the scapula not to have to lift too high to try to get the arm higher up, we can externally rotate. When we externally rotate in the shoulder, then we get a little more clearance here through the neck. See how much higher I can go? And there's so much more space in there underneath that acromion process versus if I rotate internally. Well, I'm getting stuck in there. Okay. All right. So external rotation is going to give you a whole lot more range of motion when you're lifting up overhead. All right, and that's why ballerinas hold their arms like this. They don't hold their arms like this because then those shoulders come up. Okay, so maybe you can experiment that with that in your own body. So holding the scapula down in place, lift the arm up, and then feel how it gets stuck at a certain point. Okay, I even felt a little tingle in my finger. So now I'm going to get out of that pinch. I'm going to externally rotate. So it's coming from the shoulder, but when you rotate the palm up, that helps too. All right, that's supination. And then we're going to lift the arm up, 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 and I can go so much higher now. Can you? Yeah. All right, so do a little experimental research there. And we will now dive back into our slideshow. All right, so here we have, again, those movements just for you to review. And then we have our muscles that move the shoulder, starting with the teres major. The teres major is often called the little friend of the latissimus dorsi, which will be coming next. So these two muscles, they are paired together because they do all of the same actions. Now remember, from the rotator cuff, the subscapularis also does all of these same actions. So the teres major, it attaches over here onto that inferior angle of the lower third of the lateral border of the scapula. And then it comes to the anterior portion of the humerus. So this is kind of like a see-through vision that they're giving us here. And it attaches onto the crest of the lesser tubercle of the humerus. So this is going to cause internal rotation because it's going to pull that bone and rotate this anterior attachment point toward this more posterior attachment point. Now you could imagine if the arm is held up and out to the side in abduction, as we were just experimenting with a moment ago, it would stretch this muscle. And so this muscle is going to adduct the arm. All right, now if we brought the arm into flexion, we brought the shoulder joint, I should say, into flexion, and then it would bring the arm back into the neutral position. And because this scapular attachment point is more posterior to where the humerus sits in an anatomical position, even from an anatomical position, it can extend the arm a bit. Here it is built on my mannequin. This is a picture from a while back. I've gotten a little better at building my muscles. This one's a little messy, but you can still see. Well, here's the teres major right here. And let's make sure that we don't confuse with this muscle with the teres minor. The teres minor does the opposite in terms of rotation. So the minor is an external rotator. The major is an internal rotator, and it works with that latissimus dorsi, which is a majorly big muscle. So maybe that's how you can remember the difference. So here is that majorly big muscle, the latissimus dorsi. It's the broadest muscle in the body. And then it has this itty bitty attachment point up here on the humerus. But look how large this is and expansive and attaching onto ribs and the spine and all the way down to on that iliac crest. All right, so we can't see it all pictured here on my mannequin, but here we have the specific attachment points. So it says the inferior angle of the scapula. So I have that on my mannequin here. Here's that medial border of the scapula and that inferior angle. However, it doesn't always attach onto everybody's scapula. Some people's latissimus dorsi do not. So my theories, I get sometimes students complaining or clients complaining about when they move their arm up and down and around that they feel a little snapping down here. I think those are the people who don't have the latissimus dorsi actually attached to the tip of the scapula. All right. Then the other attachment points are the spinous processes of the last 6 thoracic vertebrae. So we have 6 through 12, T6 through T12, and then the last 3 to 4 ribs and the thoracolumbar fascia, as well as that posterior iliac crest, as I pointed out a moment ago. And then the insertion point, like I said, is this little itty bitty attachment point, which we can't see here in the anterior arm, but it's inserting into that intertubercular groove of the humerus, right between that greater and lesser tubercle. So this muscle, again, does all the same actions as the teres major and the subscapularis, which are extension of the shoulder joint and adduction of the shoulder joint and medial rotation of the shoulder joint. All right, and remember that glenohumeral joint, that's the same thing as shoulder joint. So my latissimus dorsi and teres major dance, if you will. I learned this from my nephew who just turned 12 this last week, but I learned this from him when I think he was about 5. And what I noticed with my son is also when he was about 5, he did the same dance. And I've noticed other children do it too. And so I think it's just some sort of a human phenomenon. Maybe you'll have seen this before in your life. So I invite you to get up with me and do the latissimus dorsi dance. So we're going to start with the arms out to the side. We're going to adduct the arms, internally rotate the arms, and extend the arms. Okay, so the full action is a swoop. Okay, latissimus dorsi or dorsi, latissimus dorsi, latissimus dorsi. Now the dance that my family, the young boys in my family anyhow, tend to do is they do this latissimus dorsi move, flex the spine, lift their heels up off the floor. I know you can't see that, but I'm doing it. And then run. And they would run around the house on their tippy toes. But the beginning of it would always be this big swoop, run. Okay, so I hope that was at least a little bit entertaining, if not at least helpful in getting the latissimus dorsi and teres major to get stuck in your brain. Now you can also think about swimming, right? We have all those actions when we're swimming. Adduction, internal rotation, and extension. There you go. All right, back in the slideshow. Pectoralis major. Pectoralis major. Remember to say these words out loud multiple times. So we can see the attachment points here along the clavicle, along the sternum, and along the humerus. So we can see here now down below the fibers of the pectoralis major. See how it's in various pieces that kind of twist and crisscross over one another, how they attach to the arm there. So it's a fan-shaped muscle, and it has many different actions because it has all of these different fiber directions. So here is the lower piece of the pectoralis major, the lower fibers, which we also call the costal head. So this originates on the sternum, and then it inserts on the outer lip of the uh-oh, I'm gonna get tongue-tied. The intertubercular groove. Sounds like a jazz song or something, right? of the humerus there. So it is crossing over the intertubercular groove, and then it is just on that outer lip of it. And this piece adducts the shoulder, just like the latissimus dorsi and teres major did as well. It also medially rotates or internally rotates the shoulder joint. And it assists to elevate the thorax during forced inhalation if the arms are fixed. And this muscle also extends the shoulder joint. Now, it seems a bit strange that it can do all of these things, right? But it depends on, again, on what position the arm is in. So when you are looking at actions of a particular muscle and you're looking at that muscle on a mannequin, on, a cadaver, or in a picture, usually it's represented in an anatomical position, but we don't live in corpse pose. And so think of, what if this arm was in flexion? And then this muscle could bring it back into extension. All right. So we'll look at that in a moment after we go through all of these different pieces as well. Talk more about how you can remember the actions here of this muscle. Then we have the lower fibers, or the sternal head, so attaching onto the sternum and the adjacent ribs, and then inserting again to that outer lip of the intertubercular groove of the humerus. And it's also known as the greater tubercle of the humerus over there. All right. And then the actions, again, we have adduction, we have medial rotation, and extension of the glenohumeral joint. Then we have the upper fibers, the clavicular head. And so these fibers are running at a different angle than the sternal head and the costal head. So you can see the costal head's going from low to high, sternal head is going straight across very horizontally, and then the clavicle head is coming from high to low. So this is attaching to the medial half of the anterior surface of the clavicle. And then again, it's going to cross over the intertubercular groove. I'm getting better at saying it, you guys. And this one actually, it attaches the lowest on the humerus, even though it originates at the highest point of all three pieces. So this portion as well adducts the shoulder joint, medially rotates it, assists with that forced exhalation, but this one flexes the shoulder, okay, because of where it's situated. So it's going to bring that humerus upwards. And remember this piece down here, if the humerus is flexed and say the arm is up overhead, both of these pieces actually, they're going to help to extend the arm back down. Then this piece also helps to horizontally adduct the shoulder. I'm sure some of this these sternal fibers do as well, but certainly these upper fibers do. All right, we're not going there yet. Okay, so the pectoralis major dance. Are you guys ready? Okay, stand up with me. Now, the pectoralis major likes us to be here. It's like the all fours muscle, okay? So the pectoralis major is going to bring me here from anywhere I go. If I go out here, horizontal adduction. If I'm up here, shoulder extension. If I'm down here, shoulder flexion. All right, now I could also go anywhere out here and it's going to bring me back. Okay, internal rotation, right? That medial rotation. So pectoralis major dance, pectoralis major dance, pectoralis major, pectoralis major, pectoralis major dance. All right, you got it, you got it. Pec major, 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 pec major. Okay. Do you majorly got it? Yeah. High five. Okay. So I hope that helps with your studies. Okay. I know sometimes it's overwhelming to see the amount of muscles that I'm having you learn each week. But there are these tricks that can help you. All right. Okay, so now we are ready to dive into the deltoids. So again, the deltoids we could think of as three muscles. Here we have the middle deltoid highlighted in red. And then we have the anterior deltoid and the posterior deltoid. Or we can simply think of it as one muscle, the deltoid muscle. And we can see where it attaches over here on the right-hand side of the screen, along the spine of the scapula, rounding the corner, crossing over that AC joint, attaching across it over to the clavicle bone. All right, it's like a snake here. And then you guys remember this point on the humerus, the deltoid tubercle. So they're all going to convene and converge and come down there. It looks rather feather-like, right? So many different angles here. A multi-pennate muscle. All right, so anterior deltoid. It attaches onto the lateral third of the clavicle. Almost looks like a piece of that pectoralis major, right? It's just buttoned up right next to that clavicular head of the pectoralis major. And then it comes down, as I just mentioned, and attaches to the deltoid tuberosity. The action of the anterior deltoid is abduction of the shoulder, which all of them do, all of the pieces. It also flexes the shoulder joint and medially rotates the shoulder joint and horizontally adducts the shoulder joint. So these pieces down below, these three, there's my cursor. Okay, these three are unique to the anterior deltoid, but abduction of the shoulder is going to come across into play in all three pieces. So here we have the middle deltoid, and the middle deltoid attaches onto the acromion. And then it attaches again to the deltoid tuberosity. And it is just a straight shot down here. So its only action is abduction of the shoulder. Easy peasy to remember. Next up, we have the posterior deltoid. So the posterior deltoid attaches to the inferior edge of the spine of the scapula. This may be slightly on top just because it's clay and I didn't want it to fall off. And then it comes down and attaches to the deltoid tuberosity. It is responsible, just like all the other pieces, for abduction of the shoulder. And then the unique aspects of this piece are exactly opposite of the anterior portion of the deltoid. So this posterior portion of the deltoid muscle extends the shoulder, laterally rotates, also known as external rotation of the shoulder, and horizontally abducts the shoulder. All right, so let's get out of there and review the movements of the deltoid. So we have the anterior deltoid first, which is going to abduct the shoulder just like all of them will. Okay, so we could simply have a deltoid dance where we do airplane arms. Okay, meow, deltoid, deltoid, deltoid. Then we also have shoulder flexion and horizontal adduction and medial rotation. Okay, so we have deltoid, deltoid, well, let's say anterior deltoid, anterior deltoid, anterior deltoid, anterior deltoid, anterior deltoid. Yeah, anterior deltoid. All right, you could make it up. What's your dance gonna look like? Okay, anterior deltoid, anterior deltoid, anterior deltoid, anterior deltoid. Okay, then we have middle deltoid, middle deltoid, middle deltoid, middle deltoid, right? Doesn't matter what the elbow and forearm's doing. This is all, where is that humerus going? Yeah. Okay. There we go. Middle deltoid. Okay, that was just for you. Impromptu. Then we have the posterior deltoid. So the posterior deltoid, rather than flexion, it's going to extend the shoulder. Rather than medial rotation, it will do lateral rotation. So we have extension, lateral rotation, and abduction. We also have horizontal abduction. All right. So again, posterior deltoid, we have extension, lateral rotation, and horizontal abduction. Okay. Wasn't very groovy. How can we make that more groovy? How about this? Okay. Posterior deltoid, posterior deltoid, posterior deltoid, posterior deltoid. There we go. Okay. Crazy anatomy instructor. It's the end of the semester, you guys. We're all getting a little out there. But I think sometimes being a little bit wacky, just enough, sometimes helps to root this information into the brain, into the body. All right, we are back in the slideshow. And the second section of the slideshow, you can choose to ignore this week if you would like. You can move along to the next slideshow, or you can stick with me or come back to it later in the week if you feel like you have time to start digesting this material. This is really material that bleeds into next week, but I thought some of you might want a little more time to digest this. So we're going to review scapular movements first. So we have upward rotation and downward rotation of the scapula. And this movement is happening on the frontal plane, about a sagittal axis. Okay, now I know you love it when I throw more vocabulary at you, but it's for your own good, at least some of you. The sagittal plane can also, the sagittal axis can also be described as an anterior-posterior axis. Okay, so think of that like a dowel going from the front of the body anteriorly to the back of the body posteriorly. So that is the direction of this axis running through the frontal plane. And so when the scapula bone is moving on the rib cage, moving in an upward rotation or a downward rotation, that's essentially happening on a frontal plane. So perhaps you can visualize that. Then we have posterior and anterior tilting of the scapula. We haven't talked about that yet in this class. So I'm going to go ahead and pull out of the screen share here. Okay, so here's right scapula. Here's my right shoulder. Let's hark back to that frontal plane. It's like just living on the frontal plane, right? And we have that upward rotation and downward rotation that we were just talking about. And then we also have, this is really on the back of my body, right? So let's switch it back here. And anterior tilt of the scapula, posterior tilt of the scapula. So when I keep going into shoulder extension, 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 eventually I can't get my arm up any higher without allowing my scapula to anteriorly tilt. I might also flex my spine to try to get my arm higher. So those movements kind of couple together. And then when I go into flexion, flexion, flexion of the shoulder joint, I can't go any further back unless I tilt back because remember the head of the humerus sits in this socket. So I have to angle this socket further back or further forward or higher up or lower down to get my arm to go where I want it to go. All right, so that is this movement here, which is happening on what? That sagittal plane, right? About a frontal axis or a medial to lateral axis. All right, so that's what this means here. Posterior and anterior tilting on a sagittal plane about a medial lateral axis. So then we have external and internal rotation. This happens on the transverse plane. And this is about a longitudinal axis. So the external rotation brings the glenoid cavity more into the frontal plane, whereas the internal rotation turns the glenoid cavity more to the sagittal plane. So we have to think about the rib cage here and how this works. All right, so if I go into internal rotation of the shoulder joint, and then I want to keep moving my shoulder or my arm across my body, okay, then I have to move the scapula. So the scapula is sliding on my rib cage, and it's essentially sliding to be more in that sagittal plane. It's very subtle. It's not like our scapula is going to come all the way out here, right? And turn so far around the corner. But then when I go into external shoulder rotation or lateral shoulder rotation, I keep going, my scapula starts to adduct, but it also is slightly rotating because of its ride along the rib cage. And so then it pulls it back onto that frontal plane. Okay, so as I internally rotate my shoulder joint, then the scapula rides along with it at some point, and I can emphasize it as well. And so that is that internal rotation, and then external rotation, coupling with that external rotation of the shoulder joint. Okay. So the shoulder joint and the scapula, we want to remember that those are different, right? We want to think about the scapula as the scapulothoracic joint. The movement of the scapula relates to the scapula's relationship to the rib cage. And the scapula is connected, right, very directly to the clavicle bone, and they move together. Wherever the scapula goes, the clavicle bone goes. And so all the movements there we call shoulder girdle movements. Anywhere the scapula goes, the clavicle bone goes too. But wherever we move the scapula bone, the humerus is going along for the ride, right? Because it lives in there. But then we can also hold the scapula still, and we can do all of these different shoulder movements. And then they can coordinate or not coordinate with one another. All right, now we are going to continue on our journey looking at scapulohumeral rhythm, also known as glenohumeral rhythm. The definition of this is the kinematic interaction between the scapula and the humerus. And when they don't move together well, we call that dyskinesis, or the alteration of normal scapular kinematics. So now we have some pairings for you to memorize to understand how the shoulder joint and the scapulothoracic joint, and or we can describe that as the shoulder girdle, okay, how they should move together to move efficiently. So we have glenohumeral abduction above shoulder level here. And this movement pairs with the scapula elevating and upwardly rotating. Next up, we have glenohumeral flexion above shoulder level. This involves the scapula elevating, upwardly rotating, and abducting. Then we have glenohumeral adduction, and that is going to pair with scapular depression and downward rotation. Then we have glenohumeral extension, which should pair with scapular depression, downward rotation, and adduction. Next up, we have glenohumeral internal rotation. So bringing the humerus into medial rotation. And the glenohumeral internal rotation is very important. It's very important to have enough range of motion in internal rotation to avoid injuries for our overhead athletes. So you'll read about that if you haven't already in the MSK book, that an internal rotation deficiency of 20% or more increases that risk of injury. So we want to make sure that our athletes are nice and strong and flexible in that internal rotation. And that internal rotation involves abduction of the scapula. And as I was just reviewing with you, you might also describe that as internal rotation of the scapula as well. Then in opposition, we have external rotation, otherwise known as lateral rotation. And that is paired with scapular adduction, or again, could be described as an external rotation of the scapula. And we have horizontal adduction of the glenohumeral joint coming across the body toward the midline of the body. So that is pictured down here on the lower left. So this motion of the glenohumeral joint is paired with abduction of the scapula. And remember, abduction we also call protraction. Then we have glenohumeral horizontal abduction. So that is shown in this picture above, as well as this picture on the right down below. And that horizontal abduction is paired with adduction of the scapula, which again has another name. Do you remember it? Okay, retraction of the scapula. All right, so that's it for today. Okay, for our shoulder girdle part 2. Now we have, or not shoulder girdle, our shoulder complex part 2. Next week, we will be embarking upon our part 3, shoulder complex part 3, the last part, okay? And that will be also wrapping up all of our muscles that we will be reviewing this semester. So be excited about that. All right, so review your muscle motions, say the names out loud, do the actions as you say the names. I find that is so helpful. And then if you have time, keep reviewing the scapulohumeral rhythm, which movements go along with each other, okay? The shoulder girdle and the shoulder joint, or you can think the scapula and the humerus. How do they move together? What movements are paired, or what movements should be paired ideally for some nice smooth biomechanics to happen in there. All right, and we'll explore that a bit more next week as well. And I look forward to sharing that information with you. All right.